Okay, so I'll keep admitting people, but I'll start out just by introducing myself. My name is Evelyn Rajan. I go by Eva. I'm a third year at Toro College of Osteopathic Medicine in Harlem. I'm the chair of the New York Emergency Medicine Student Council, and I'm really excited to have everyone here today. Just a quick announcement, we have sent out the application for the new council. So anyone who is an MD or a DO student in the state of New York is able to apply to be part of it. We actually have 17 medical schools in the state of New York, which is the most in any state in the country, which is awesome. I know we have students from other states on the call. So if you are from another state, there most likely is a state council in your state. You can reach out to me if you're wondering if that's the case, though. So yeah, the application is due April 2nd. And today we have, just to take a break from moderating, I figured it would be good to have Adam Halpern moderate this one. He will be applying to pediatrics this fall. He's a classmate of mine at Toro, so you can take it away, Adam.
Hello, everyone. It is an honor to be the moderator for this panel on pediatric emergency medicine. We have fantastic people on this panel, which each of them is going to introduce themselves. But I just want to welcome everyone to the panel. This is meant to be very informational, but also can be conversational. It's fluid, so the topics we have addressed, but we can go, however the conversation goes. So you're welcome to write in the chat to express any additional questions you have, or thoughts, feelings, reflections, whatever comes to mind. But first and foremost, my name is Adam. I'm a third-year student at ToroCom in Harlem. I, as Eva said, will be applying to pediatrics, as that is my love, is pediatrics. And I'm originally from New Jersey. And now, without further ado, I'd like to open up to my panel here of amazing people. I'll have each of them introduce themselves, kind of what their name is, what their title is, if they started with EM or PEDS before going into pediatric emergency medicine, and what their favorite kitchen utensil is. Mine is a ladle. For all these purposes. So we're going to start with Mark.
Hey everybody, my name is Mark Hanna. Right now I am finishing my second year of Pediatric Emergency Medicine Fellowship at Maimonides Medical Center in Brooklyn, New York. I'm originally from Egypt, but I've been in New York City my entire adult life. After med school, I did a year of research at Mount Sinai. I did my residency at SUNY Downstate and Kings County in pediatrics, and I'm doing my fellowship at MIMO. My favorite kitchen utensil, I'm gonna say a knife. I like to cut up food. I cut up pineapple probably more than I should, so that's a fun one. Yeah.
Wonderful. Thank you, Mark. Let's go on to Joanne.
Hello, everyone. Good evening. My name is Joanne Agnant. I'm a pediatric ER attending at NYU Langone and Bellevue Hospital Center, and I'm also the Associate Program Director for the Fellowship Program. I am originally from Brooklyn, but moved to Jersey around high school, and I'm still living in New Jersey, so I'm also a Jersey person. My favorite utensil, I guess I don't even know what you call it. It's like an avocado tool, and you can cut the avocado and remove the pit. I'm excited every single time I use it because I've actually injured myself with a knife trying to eat my avocados.
Wonderful. Thank you very much. Let's go on to Molly.
Hi, so I'm Molly Moseley. I am, I guess, originally from Philadelphia, but I've been in New York for last almost 5 years now. I actually did my EM residency at Jacobi/Montefiore, and then now I am a first-year pediatric EM fellow at the Children's Hospital at Montefiore. Oh, and my favorite kitchen utensil, the one I guess the one that I use the most is a wooden spoon. It's very versatile.
A classic. Let's go on to James.
Hi, I'm James Meltzer. I've been in New York my entire life. I grew up in Queens. I went to college in the Bronx, medical school in the Bronx, and then I did residency at Montefiore, where Molly's at, and then I did my fellowship at Jacobi. I think around the same time, Yvonne Giunta was doing her fellowship. Yeah, it's been a long time since I've seen her. And I've been at Jacobi for a good 16 years or so now. My interests are research and ultrasound. And my favorite kitchen utensil, I use my hands a lot. I'm gonna use that. But other than that, I'm happy to be here.
It's the kitchen utensil you always have with you. That's perfect. And let's go on to Yvonne.
Hi guys, so I'm Yvonne Giunta. I am the Division Director of the Pediatric ED at Staten Island University Hospital. And I went the PEDS route. I did my PEDS residency at Downstate, Kings County. Then I did a chief year, which was a separate year for just strictly pediatrics at Staten Island, where I was selected to be the chief for the year. And then I went on to what was then Schneider's and is now Cohen Children's Hospital. And I did a 3-year fellowship there. And then I came on as division director directly after that, back at Staten Island. My favorite kitchen utensil is, I'm gonna stretch this out because I love to cook. And I'm gonna have to say it's an appliance, really, not really a utensil, but I'm gonna go with an appliance. I'm gonna go with the mini chop because I love cooking and I could use that for like everything from chopping up garlic, making smoothies, making crepes. So I'm going with the mini chop. Yeah.
Great selections all around. Welcome to the panel. As I propose questions to everyone in the panel, there is no particular order. You're welcome to answer as you please, and unmute yourself to answer any of the questions as you see fit. The main topics that we're going to try to hit are why PEM, why Pediatric Emergency Medicine, the daily grind, books, the residency fellowship process, pick me please, how to get into a PEM program, and if we have any final thoughts and last minute comments. So we're going to first start off with the obvious one, which is why PEM? So the question is, why did you choose pediatric emergency medicine, and why did you choose the specific path you chose, either starting in EM or starting in pediatrics?
I could take that if you guys want, or I don't know if you have a system for how you want to do it.
No, go ahead.
All right. So for me, it was very much obvious at the PEDS route. And Adam, very much like you, I thought I was just general PEDS sort of all the way. And it wasn't until my 3rd year of residency that I realized that general PEDS was going to bore me. And so I needed to find something more, but I didn't even realize it was going to be PEM till I did it. I have to say that when I did like my rotations in cardio, everything was, kind of the same, like your routine. Everybody had a murmur. And then I did nephrology and everyone had proteinuria. And then I did whatever, GI, and everyone had diarrhea, or colitis or something. And then when I did PEM, it was just like, it just clicked that was perfect for me. I loved the acuity. I loved the procedures. I loved that every day was different. I'm a multitasker. So for me, that was perfect. It was just like every day was exciting and new, and it was a perfect fit.
Mine's very, very simple. When I was in medical school, all I cared about initially, why I chose PEM was, as a med student, you absorb a lot because you want to be good and everything, and you're there to watch and learn. And I just wanted to be happy as an adult in my job. And the happiest people were in pediatrics and emergency medicine. Mm-hmm. And we're formed by the people we meet. And I met an attending, her name is Walesia Robinson, and I wanted to be exactly like her. And she was a PEM attending. And when I was in residency, I met a woman named Benita Shah, who I still aspire to be like to this day. And she formed my desire to do that. These are the heroes we look up to. And I still believe that PEM is for the most part, comprised of the happiest group of people I've met by and large across specialties. So, you know, there's nothing easier than that for me. And it's really simple. It's just binary, you know, like it's a binary choice. Like, am I going to be happy? Yes or no in the job that I work at? And to this day, I just got off a really, really, really grueling shift. I'm still pretty happy. So it's a win.
I guess I could go next. Yeah, I thought I was going to be a general pediatrician too. I love the relationships. I love dealing with kids. It's very rewarding. It's very easy, right? You're not worried about you know, there's not, the people around you are generally good people and they're in it for the right reasons, right? When a child makes a mistake, you can kind of in your mind chalk it up to just them being a child or not, you know, maybe their parents or their opportunities weren't there. But you know, it's harder with an adult that's drunk or, you know, is continuously making bad choices. So it's definitely easier. But I thought I was going to be a general pediatrician. I thought I was gonna you know, develop those relationships. But once I got into pediatrics, I realized particularly in the clinics, I was being forced to kind of see patients very quickly without being able to like do the best that I could with each person. And plus there was this whole idea that, you know, if you're in the clinic, you're trying to they're trying to squeeze you to see as many patients so that they can make money and that sort of thing. And I found that, you know, I like taking care of sicker patients. So, you know, PEM afforded me that. The PICU part of it, I was thinking of doing that at one point, but for that, I found that like maybe 50% of the patients that you would see in PICU kind of had this maybe chronic condition or something like that. They weren't your regular kids. And I really, you know, my just general pediatrics wanted to take care of regular kids. So, and I think like everybody else is saying, you kind of see where you fit in. You see the people around you that you're like, hey, I get along with these guys. So I think, you know, had I been around maybe surgeons that were happy and love their job, maybe I would have chose that. But that's kind of what led me to pediatric emergency medicine.
I echo what everyone is saying. I forgot to mention that I also did a pediatric residency. I was in Philadelphia at CHOP and then came to NYU Bellevue for my PEM fellowship. And I've always wanted to be a pediatrician. I think that you definitely feel where you belong, just like everyone has mentioned. And I just found that when I was in the emergency room, the pediatric emergency room, I was learning from every single patient. I was so excited. I'm also a multitasker. It just felt like where I wanted to be. From the minute that I got there to the minute it was time to leave, I found myself staying even longer. And so that's what I would say. I went into every rotation as a medical student, like, I'm going to enjoy this. I'm going to learn. I'm going to see if this fits. And I always got drawn to pediatrics. And as a resident, I went into every month with, I'm going to see if this fits. I enjoyed the PICU, but I hated rounding. I enjoyed, you know, my continuity clinic, but like developmental like counseling and anticipatory guidance was not me. In between my residency and fellowship, I was a hospitalist for a year. And I just needed a break before interviewing for fellowship and everything. And I also enjoyed it, but I missed the diagnosis part. You know, by the time the patients got to me on the floor, I already knew what was going on and I had to like round again. So, I think that you'll feel where you're meant to be.
That was actually like the opening line of my personal statement, is that I wanted to give the sign out, not get it.
I guess I'll finish up here. I come from a little bit different timeline than everybody else here. When I was in med school, I pretty much knew I was like, I love emergency medicine, but I also loved pediatrics, but I knew I wanted to do emergency medicine, and I just didn't know whether I wanted to do emergency medicine or do pediatric emergency medicine. And like everybody else is saying, like the emergency department always felt like a home to me. Like the people I just get along with, everybody's pretty easygoing. You're pretty much joking or practical joking the entire shift. And it's a bunch of fun patients to see. It's new. And if you have ADHD, it's very easy to continue throughout the day. But somebody, I remember I was trying to figure out whether I should go into like pediatrics or EM first. And somebody asked me when I was in med school, they said, do you want to never see adults again? And for me, that was a no. I still personally, when I finish Penn Fellowship and still during Penn Fellowship, I want to see adult patients. I love what I term as my adult babies. I love my elderly patients. Some of them have the greatest stories and the greatest personalities. So for me, I always wanted to do both. So that's why I chose the EM route first. And I actually went into residency thinking, okay, try and negotiate with myself to not do a fellowship because it's 2 more years of training and most EM people don't do fellowship. But throughout residency for me, just every time I stepped into the pediatric ER, it was just, I had the best time, like everyone else is saying. I always loved seeing my patients. They're just cute as a button. You can't be mad at them for not taking their medications and getting another seizure, which you can be mad at your adult patients. So it's just a totally different world. So for me, I will I will practice 50-50, but I think the PEM aspect just will make my burnout rate a lot less than some of my other colleagues, and in general will just make me happier.
Thank you. So then a nice transition here to asking a question about differences in PEM physicians depending on where they started. So the question is, are there significant differences between PEM physicians that started in pediatrics versus ones that started in emergency medicine? And if so, what are those differences?
I guess I can start with this one. So there are for sure. I definitely feel a little bit lost sometimes when my colleagues start talking about all the syndromes that they had to learn during pediatric residency that I kind of missed out on. Learning a ton this year, so trying to catch up. But there's definitely a difference, I would say. But in general, I think after the total of 6 years for everybody, you kind of end on with the same amount of knowledge, I'd say, or the same way of like practicing, I guess. There are, I guess, differences of opinions in some of the older patient population. But in general, I think it's the same. The only difference would be going forward, whether or not you, like I said, want to only see children, or whether you want to split your time, or even not even unevenly split your time as well, seeing adults and kids.
Yeah, I totally echo that too. Being in a program where the PEM division is under the umbrella of emergency medicine, right away I saw the stark differences between, like an EM grad who's a PEM fellow, their education is emergency medicine, right? That's what their residency was. Ours, or those in pediatrics. So there's the academic pediatric portion that EM people are not exposed to as much as we are. And then there's the emergency medicine knowledge that we never got in peds, like concepts like flow. On a procedural level, the EM residents are so much better adept at hallmarks and staples of emergency medicine, like ultrasound, like doing any procedures. Like I remember as a peds resident, our procedure, like the big one was the LP, right? Or, but a pediatric airway, I don't know from where I've been too many pediatric residents that are going to be exposed to an airway to the same level as the average or whatever emergency medicine resident. So they see in my opinion, they see acuity and procedural medicine far more in terms of like volume than I did, for example, in my residency program. And yeah, so it's just the differences in education where you come from. Like a concept like flow, I think is a good stark example. Like I didn't know what flow was as a PEDS resident, you know, because you have your clinic patients and, you know, at some point they're going to stop accepting patients. Like at 5 o'clock, that's it, no more patients come in. And that's not how it is in the ER.
And I would imagine as an EM resident, the part that you kind of missed out on is what like a normal healthy kid is supposed to look like, because every patient you're seeing is coming to the ED and most of them are not your normal healthy patients. So you probably have a different level of comfort with like what's normal for a kid who's not terribly sick and calling it normal.
For sure. You see like I'm not even a full year into my fellowship, and every single one of my classmates has either called me or texted me about a PEDS case that they're like, is this normal? What is this? Send me pictures of rashes. Like we definitely you don't get the same knowledge base of like what's normal for a 1 week old, what's normal for a 1 month old, like all of these things you just don't learn in emergency medicine residency, where in pediatrics you do. Mm-hmm. And that's a lot of PEM actually.
Yeah.
So yeah, just to add on to that, you know, you think a lot of pediatric emergency medicine is general pediatrics, right? A lot of kids use the ER, particularly in cities where you don't have a lot of good primary care or readily available primary care. A lot of kids use the ER as their primary care. So, you know, if you're saying like maybe 20% of what we see is emergencies, and that's a little bit of a stretch probably. So like the general pediatrician, when they come if they were to work right out of residency, they'd be great with that 80%, maybe even a little bit of the emergencies, but you can tell like when the emergency comes in, the EM resident is that much more ready. They're used to the setup, right? They're used to the ABCs and going through the evaluation. There's a lot more confidence that comes with that. But for the other 80% of the patients that, you know, like Molly was saying, the rashes or the colds, or, you know, you're, you know, worrying about like, hey, this kid's not vaccinated. Now, now we have to worry about tetanus and that sort of thing. They're going to have trouble with that. For the emergency medicine versus the PEDS resident applying to pediatrics EM, some places don't allow, I'm sure Molly, I'm not sure if you came across some troubles with this, but some places don't offer spots to EM residents. So they're fewer and far between. But I'm not sure, Molly, maybe you could speak about this too. When we've had emergency medicine residents come through us, we change the fellowship a little bit, right? We change what they're getting, right? So they may have done tox in, this is an example, but say they did tox or something like that during their EM residency. You know, now during their PEM fellowship, they're going to do NICU. They're going to do things that they didn't necessarily see. So I imagine, like Molly said, you know, maybe not right after fellowship, but after some time, you kind of catch up. You know, you kind of understand, you kind of make it what you kind of fill in the gaps with what you need. Can you speak to that, Molly?
Yes. Yeah. So I totally agree with that. Like, I feel like I have a very steep learning curve, and I've learned so much already. And it's all like about pediatrics, but when I was applying last year, there are some programs, like the pool for you to apply into is a little bit more limited when you're coming from an EM residency. Not to say that like programs don't want EM applicants, that when they are programs that do accept EM applicants, and there's plenty of places that do accept EM applicants, but you also will run into problems where, like, for instance, there was a program last year that I had wanted to apply to and talk to the program director, but they said that they weren't accepting EM residents that year. So it was like I could wait a year and apply with the next cycle, or I could just be like, I'm not going to go to that program. So it is a little bit more limited for if you're coming from like EM to PEM, but I don't think there are very few people that actually do EM to PEM. Like I talked to like people from not my program, not anywhere that I know, because I didn't, it's like 3 people twice removed, because they're so few and far between. And some of the people that I talked to who are EM to PEM, and they say there's only like 200 people in the entire country that do EM to PEM. So it's a much smaller portion of the PEM population in general, but hopefully growing. We're recruiting. And yeah, I do more like clinics and NICU, currently on cardiology clinic, which I love, and things like that to fill in my like pediatric knowledge gaps.
The other piece is when you do EM, and most EM places I think are still 4 years. Many times you'll only have to do 2 years of PEM afterwards. Whereas when you do Peds EM, it's 3 years of Peds residency, 3 years of Peds EM fellowship, right? I said that wrong, but when you're doing it through the Peds route, it's 3 and 3 versus 4 and 2. And so what happens is, what Molly's saying is that, people are used to having, say they have 2 people each year for their fellowship. When you take the EM person, it messes up that kind of like 2-2-2. You end up with like a 3-2-1. And so at Jacobi, we had 1 year, like when I was a fellow, we were 3, 4, and 0, because of the cycle. So it depends what they're willing to accept. But what are they doing for you now, Molly?
I don't know. I'm their unicorn.
No, are you doing 2 years, or do you have?
Yeah, no, I'm only doing 2 years. So I don't know whether they'll take. It wouldn't be. It's not for next year. It's like the same amount per class, but like, I think it offers because I graduate with the technical class above me. They will be able to take an extra person when I graduate, if that makes sense. But then that'll also throw off their cycle. So hopefully I can recruit an EM applicant.
I think it's also worth mentioning, I think there are maybe 1 or 2 programs, I don't know where they are, but that offer like a PEM route, a PEM EM route from the beginning. Are you guys familiar with that? Any of you familiar with that? Maybe more than me, but there's one, I think there are 2 in the country that when you apply, it's like straight track through to PEM.
So that is actually the Peds EM. It's a combined residency program, which I actually looked at. It's pediatrics and EM, and they're generally 5-year programs. So there are like 2 or 3 in the entire country, but with that, you can't actually sit for the pediatric emergency medicine boards. You can only sit so you can be dual boarded, but it would be in pediatrics and emergency medicine, and you can't sit for the pediatric emergency medicine boards. So that's the only big difference in that. Mm-hmm. Not sure if administrators care.
Probably not.
Joanne, can you speak to the specifics of PEM training at NYU? Like what the leading up to the residency, going into the fellowship, like what is the process like there?
Meaning in terms of the curriculum, or?
Meaning in terms of kind of length and timeline. I'm not sure if it's standardized throughout the country or if there is variability.
It's pretty standardized for us. We haven't actually had any EM residents go into PEM, so we haven't adjusted it recently. But generally we have pediatric residents who have completed 3 years, and then they come and do 3 years of fellowship. One thing that I was going to mention, one of the differences I think between a PEDS person going into PEM is that I guess that 3rd year is focused on research, and an EM person going into PEM, they do 2 years with the thought that they don't have to do research. Is that correct, Molly? Or?
So
I think yeah, go ahead.
yeah, so there's, so you guys have like this like long, basically requirement for research that you have to send in for each fellow after they complete their research and prove that it's great and all this stuff. But for EM through like for PEM EM candidates, all there is that like my program director has to like check a box that I participated in a project, and it doesn't have to be research. It can be just a QI project. So yes, there's no real research requirement.
But I think also that what's mostly removed from the EM residents going into PEM is they don't have to do some of the rotations that a PEM fellow that one from PEDS had to do, for example, like ortho, ENT, regular ED rotations, like all those are removed. So once you take all those out, you're down a year, right? Because as a PEM fellow, you have to do like, I think 2 blocks in the adult ED. You have to do ortho, ENT. I don't know, there's a bunch of things. Things could have changed. I did fellowship a while ago. But once you remove all of those, you're like down a whole year. And the research, yeah.
Thank you very much. We're actually going to move on to some of the day-to-day, but if you do see a question in the chat and you're not one of the active speakers, you're more than welcome to type in and reply to those people as just another option. But I know a burning question that's on a lot of people's minds is the kind of the work hours of PEM and whether or not there are people and opportunities for people that are work in the emergency room as in pediatric emergency, but also do general pediatrics. Are there people that do that, and how do they make it work?
I'm not sure why anyone would want to do that. I'm just going to be honest. I guess you could, but salary wise per hour, you make so much more in PEM that I don't think anyone would ever look to do that really. Maybe when I retire, but I don't know. I've never met anyone who's done that. Anyone else?
For me, as a fellow, the only time that I will work a Gen Peds clinic is if I am not on duty and want to make money moonlighting, because an easy opportunity is available for me. When I actively try to find moonlighting jobs or moonlighting gigs or whatever, I look to get them in ERs. But sometimes just due to scheduling inconvenience, like a clinic is available and will want us to fill it, the PEM fellow. So I'll take it because that's easy money, I guess. I say that not cavalierly. It's just, it's not as acute as the ER.
Yeah.
I don't know anyone now who splits their time between a generalist and PEM. In the times I've moonlighted, it's in other emergency rooms, or I know people who do urgent care like PM pediatrics. However, when I was in residency, my program director worked in the emergency room. He had one day of the week that he was a pediatrician, and several times during the year, he was a hospitalist, but he was like one of the grandfathers of emergency medicine or of pediatric emergency medicine. And so not anyone, I don't know anyone else who does that.
Can I just wanted to add something onto this, this EM PEDS route. Like, if you're in PEDS EM and you have an EM resident or so, you know what they're lacking, right? And when you have a PEDS resident, you know what they're lacking too. So I don't think doing an EM residency and then a PEDS residency is the same as being PEM trained, right? Like you'll know cervical spine fractures from your EM residency, but you don't learn pediatric cervical spine fractures in your PEDS residency, right? Similarly, you don't become an expert on pediatric orthopedics in either of those spots, right? So, PEM fellowship is a specialty in that, that you're kind of like, you're a GI doctor, like a peds GI doctor, where you're a master of pediatric GI problems, right? That's why the fellowship exists. Similarly, PEDS-EM is that kind of specialty where you're the master of those particulars, right? So I don't think you get the same, I mean, you could do it, but I don't think you're of the same caliber and I imagine that's why Molly wanted to do PEM rather than, I keep talking about you, Molly, but you're the unicorn here. So, but I imagine that's why you really want to get that specialty training.
Yeah, so we're gonna go into the pick me please category here now, because I think this panel has excited a lot of people here to go into PEM, and now they're thinking, well, now how do I do it? Pick me please. And so a burning question then is, what qualities and experiences are you looking for in a pediatric resident that you would then accept them as a PEM fellow?
If I could be so brave as to answer first, because I am not an administrative position at all. So I want to give a very honest answer that I think will not be maybe in line with the admins who are actively interviewing. So when I was a resident, I had the same fear that I think most PEDS applicants have. Like, am I good enough? Am I even going to match? Because it's such it is, in my opinion, and I think arguably the most competitive fellowship to match into out of pediatrics. It's notoriously difficult. So you need to do everything you can in your residency to make yourself attractive. And first you got to want to do it. So when I applied to as many programs as made sense for me. And I learned very early on, because my residency had a PEM fellowship program, that research is something that people get excited about, and research isn't as boring as people think. Like the mundane, there's a lot of avenues within research that you can get your name on something and you can talk about it. You want to be attractive to a program, so you have to do attractive things as a resident. And like, to me, what I thought would be attractive is like scholarly activity, getting involved with your hospital, doing things like this, like coming to meetings. And what I found to be super good at networking was getting your stuff accepted at national conferences as a PEDS resident. Like, I was always that like one random PEDS resident at ASAP who was presenting, and then I could meet people. Like, oh, you're at this hospital, oh, you're at this hospital, and you talk to people. And then even if they forget all about you, your name's in there a little bit. So if your name now comes across their interview candidate list and you got sorted out of whatever filters they're using, they're like, oh yeah, I met that kid in like San Francisco. He was doing something on whatever. He was a good guy or something like that. Because, if you want it, like, you got to go out there and do what you need to do to make yourself an attractive applicant. Because the numbers don't lie. Like, year after year after year, it's a really hard fellowship to match into for a lot of good reasons. So you just gotta go out there and get it. And if you truly want to do this, have an honest conversation with yourself on like, am I willing to move to like the middle of nowhere, California, to do this fellowship? Or it's just, yeah. So I'd say like the pick me please part, that specifically, do the things that EM people do before you apply for fellowship. That's just my humble opinion.
So I could speak a little bit to this. I do a lot of interviewing with my group for fellowship. I think it's really the whole package, right? Just like you're saying, Mark. It's first and foremost, I think the most important thing is, can I work with this person? Am I going to be happy having this person next to me on an overnight shift with grueling, with difficult patients and having to get through the cases there? Am I going to feel comfortable, or am I going to be annoyed by them? And are they not going to be able to complete their tasks? Are they not going to follow through? So that you kind of get from a couple of different things. One from the interview, two from I call Christine Muscala, Mark, Hanna. So when I have someone from Maimonides that's applying to Jacobi, we make phone calls. We talk about them, right? I look at their letters. If I get a letter from Yvonne and that this person's really good, we'll call Yvonne and say, hey, I haven't talked to you in a while, but hey, what do you think about this person? Are we going to have problems? We look at everything. We look at board scores. We look at what schools they went to. We look at whether they're foreign grads or not. And nothing really is a DNR. Nothing's going to totally knock you off the list, but it all counts. And like Mark's saying, it is if you're a research type, get involved with research. If you want to do PI, do PI. But if you're just coming in with just hey, I'm good, I do my work, and you don't really have much more, it's not as attractive. You need to have some substance really when you get in there. But if you have this honest conversation, find out, are you a superstar? Or are you not a superstar? If you're a superstar, then maybe you can limit what you're applying to. But we have Jacobi residents that were like, hey, you're not really a superstar. You're pretty good, but you're not a superstar. Maybe you should kind of think broadly. And if you do that, there are a lot of programs out there, a lot of great programs. They're just in the middle of nowhere. So at that point, you kind of decide, who you are and what you're willing to do. But you're more likely going to match if you think broadly. But yeah, everything counts.
Yeah, I'd have to say that making personal contacts, real life contacts, is huge, because we're still overall a pretty small community. And when application season comes out, we all start texting each other, Alex Arroyo and me at MIMO are good friends. I'll be, hey, what's up with this person? Or like, oh my God, please take this one, whatever. So making contacts with people is huge. So if you know that you're interested in PEM, doing your a rotation when you're a PEDS resident or whatever way you go, doing a rotation at a hospital that has a PEM fellowship is really important, because even if you don't match there, they might be able to put a good word out for you somewhere else. It's just really good to make contacts with people, and you never know. For me, for example, we don't have a PEM fellowship at my hospital, but I know a lot of people that do have PEM fellowships at their hospital. So if I know you're applying, I will reach out to those people and say, hey, you have to at least interview this person, or, so definitely making real life contact is huge.
I echo what everyone has said, and I say bring your passion. I love interviewing a resident that you can tell absolutely love what they do and are excited for their next prospects. So, someone who loves research and therefore has gone out and presented at conferences is definitely someone that I'm going to look at. I want their letters of recommendation to also show that they love working with patients, that they're great team players, that just like James said, they follow through in taking care of their patients. I think one of the best things I ever read from a letter of recommendation is that that faculty attending would want the resident to take care of their own child. So I think definitely making sure that you show your best foot in your residencies, network, do what you love. If it's not research and it's advocacy and it's community outreach, whatever it is, whatever you see yourself doing when you're done, fellowship, I think, is what you should start to build.
Thank you very much. I know that two questions that we got in the chat that I think are related to this topic then, and speaks to really the fellows, is, what are some things that you did that you think made you stand out to, in the interviewing or the application process?
Is this for residency or for fellowship?
That's a great question. We things that you think made you stand out, I guess, in regards to your PEM fellowship, but it can apply to the longevity. You know, it could have been something that you did in medical school that played a role in the long run to getting a PEM fellowship.
Yeah, so personally, I don't think there was anything in my med school that I did that I specifically got me into fellowship. But what Joanne was saying is like just being passionate, I think kind of helped me out. And I'm going to be very honest. I'm like not really into research. I love reading research. I think it's great. I love dissecting articles, but physically doing the research, I don't love, and I'm sure that also like hurts Jimmy as well over there. Um, but I just went into residency being totally passionate about like PEM and pediatrics, and I like met with my program director in residency and was like, okay, how can I get more pediatric education? And I was like, what electives can I switch around that I can do that is more in peds? How can we create like a pediatric tract in our EM program? How can I be the leader of this? And luckily my program director was like he was great about being like, sure, you want to like roll this boulder up a hill, do whatever you want and I'll help you however I can. So I like went into residency being like, okay, I want to do this, I want to do that. And so I did do a lot of that stuff. And I think for me applying to PEM, that's kind of what shows in my application is that I went and did all of this stuff to try and create things that I thought were like important, like creating the PEDS tract or working with the neonatologist to create a like emergency like neonatal day for our residency and things like that. So I think just follow your passions really, and that'll come through in your application. Don't do stuff just to like pad your application. I think people can read through that pretty quickly. So like do things that you're super passionate about and that'll come through and people will like love you for it, I think.
I couldn't agree more. So I'm going to tell you like what I think helped me get into a fellowship. And the one word answer, is effort. Not everything always pays out, but effort is a lot of the best things that happened to me as a resident were because of effort. So the day I turned in my papers, like all of you here, I knew I wanted to do PEM, and I went, I matched into my residency program. I was super hyped. I was walking into Brooklyn, and I walked right into the fellowship director's office. Her name is Jen Chow, and I was like, "Hey, I want to be a PEM fellow in 3 years. Like, tell me what to do. Help me get involved." And she walked me right into the ED, and I met a whole bunch of people there. And she introduced me to a guy named Dr. Sinnert, who I did my first paper with. And I was like, oh, okay, research is cool. And then I found an idea that I liked. And it was weird and crazy. And it's like drones flying around Brooklyn. And it was weird, but I rode that. And I was passionate. And it's my baby. And I want to take that forever. But I put an abstract together with that, sent that out, got to present at a bunch of conferences, and then interviewed from there. That's just my story. So like research was like my thing, is my thing. I'm going to tell you about other, like my crew in residency. It was me, my best friend, Danny Holmes, who's now my co-fellow. And her thing and her besties thing, Jen, one of the residents that was in our like group of people who wanted to do PEM, they really, really were passionate about, gun advocacy, rights of minorities in the emergency medicine department. So they went to rallies, they organized a whole bunch of events. They did community outreach when they were residents, and they're still doing that. Like it just, you find what you love and you do effort. And then there's other leadership positions. Julie Raymond from the AAP sends us emails. I think more than any other single person sends me an email. And every month or so, we get a letter that says, what's new for residents or fellows? And it's full, literally just full of opportunities that you can get out there and apply to. And if it's not the AAP, it's ASEP or SAEM. And it could be in whatever you want. If you just put the effort out there, I don't know if you're going to succeed 100% of the time. But when you are successful at something you are passionate about and that you put yourself out there to try something new, the rewards pays dividends later on. And I think that's the best thing you can do as a resident is try. You won't always succeed, but when you do succeed, it's an accolade that you can then demonstrate to a program and be like, hey, look at me, like pick me because I will do this for you and for our institution.
Thank you very much. That's very helpful to a lot of people, especially, we're as medical students, it's the brainstorming starts now, having that reflective process on what you're passionate about, what makes you happy, what can you see yourself doing outside of the hospital, every day. And so starting that reflective process now can only benefit us moving forward. We're getting into the home stretch here, and I'm definitely mindful of everyone's time. But I do want to hit on something before we get to our final question. And that's one more about a little bit of the nitty gritty of the job. And that is about work-life balance. So what are the typical work hours of somebody in PEM? And what does the work-life balance generally look like?
Well, as a mom of 2 kids in administrative roles, I could just answer at least part of that. I can't imagine a better way to be able to balance my life than doing something that is shift work, because I'm able to, I don't miss ever my children's activities. If I'm scheduled for a shift, I'll switch to a night shift. If it's a day shift, I'll switch to night, I'll work it out just to be able to get to where I need to be. There's opportunities if you choose them to be administrative, and then you can cut your clinical hours and do more administrative things. So you're spending a lot more time in meetings and less clinical hours, but of course you're getting compensated for that financially, but you do have less clinical hours, which is nice. Shifts it depends on the place. Usually shifts could be 12 hours, just like, your most residency shifts are for EM residents or even peds, but then your shifts could be even just 8-hour shifts. Like sometimes my shifts or 10-hour shifts, 7 to 4, 4 to midnight, overnight shifts, 9 to 7 a.m. or so, so there's all different types of shifts. And then there's, of course, the dreaded 12-hour shifts, but you never have 24-hour shifts. So that's good. But as far as being able to have work-life balance, I think shift work is the perfect way to do that, because you can choose a set schedule where you might be working less desirable shifts, but for that in return, you get a set schedule. Whatever, as a mom, I never had to miss, literally, I never miss an event because I'm able to somehow make it work. So.
Yeah, I mean, ditto, same thing. Exactly. I got 3 kids, and I'm able to stay home and do their things. I have to coach a softball game this Friday, so I can either take it off, or I could maybe switch into the overnight, and things come up. It's pretty easy to get through. Most people, I would say, in academic PEM, they're working maybe 30 hours, 27 hours a week, something like that. And very, very, very manageable.
With an administrative role, I was able to go down as well. And I love the shift work and not having to work a 9 to 5 every day. The times that I do have maybe several, if I have 4 8 to 4s in a row or something, or I'm so exhausted by the end of the day. I'm just not used to it because I'm not an early sleeper. And so waking up that early is difficult for me. However, it's really important to know yourself and know, are you a night owl? Are you an early riser? Are overnight something that's okay for you? Because starting off, you will have to work overnights. You will have to work weekends. It's definitely easier, I think, than my non-medical friends to move my schedule and move shifts, but knowing that sometimes, you'll be at work at night or you'll be at work on the weekends on a Saturday or something.
So we're going to head into our last question, which is pretty much final thoughts, and we're going to go around and we'll have each of our panelists speak on just final thoughts that you want to leave with the entire group here. And I'll pose the question, what advice would you give to medical students that are pondering whether or not that PEM is a right fit for them? So final thoughts, we'll start off with Molly.
I think it goes to say, like, just especially in medical school, you're going around on rotations and it's kind of like dating. So see where you fit, and that actually really does like make a difference. You should be happy to go to work every day. Like, we all became doctors because we want to love what we do, and the people that you surround yourself with, you'll figure out like kind of where you fit and who you love to work with and the group of people that you love to work with. Just in terms of deciding like EM or PEM, or EM to PEM or PEDS to PEM, it really just, do you want to not see adults anymore? And some people are like, ooh, yeah, adults are gross. But that's my only real thoughts. If you guys, and coming from like EM to PEM, if I can give Evelyn and Adam my email, if you guys have questions, it's a very small group of people that did that. So if you have questions on that type of process, I'm happy to answer questions.
Thank you very much. Yeah, we'll be sure to collect, everyone's contact information so that it's available for people that have extra questions. We're going to transition to Yvonne.
All right, so I would say obviously everyone who's here is interested in PEDS, so that's the easy part. But if you find that you need like a bit more excitement, for me personally, I felt like I didn't want to do like well child exams, immunization forms, checkups all the time. That just seemed a little bit too boring for me, and you want something more exciting, anticipated, like unexpected sick kids coming in, procedures, and most of all, not rounding. That was huge for me. Shift work, all of that is extremely, if you're the type of person who wants to sort of multitask and really just be able to get a little taste of everything and not just focus on just one specialty alone, or even just general pediatrics, PEM just is perfect. Lifestyle wise, it's great. Salary wise, we didn't really touch on, but it's much more desirable, I think, economically versus just at least general peds. As far as with comparing EM and PEM, it's a very different conversation. We need a lot more time to go into the details of that, but I'm happy to answer any questions about that if you guys want to send them over. But mostly it's a career that is extremely rewarding. Almost every shift you come home and feel like you made a difference. Even the simple days like nursemaids and foreign bodies are satisfying, but then of course those times when you save a child's life, much more rewarding. So I absolutely love it. I can't imagine doing anything else. And even when I one day retire, I can't imagine retiring to anything but this. So anyway, good luck, guys.
Thank you very much. We'll go to Joanne.
I'd have to repeat, follow your passion. You definitely want to feel happy when you're at work, or even when you're stressed, knowing that you're where you're supposed to be. So I think as a medical student, definitely try to do an elective so that you can see the environment and see how you feel. And you want to kind of look at your attendings, because residency is going to be difficult, but look at the attendings and see if you would be happy doing what they're doing.
Wonderful. Thank you. And we'll go to Mark.
I would say first and foremost, believe in yourselves, trust the process, and do something outside of your comfort zone. Just try something interesting and fun. And the last thing I want to say is don't forget to enjoy it. Because when you're a medical student, you're a resident, when you're a med student and when you're a resident, it's easy to feel stressed and then it's over and all you're left with are the good memories. And you wish you could go back to that time when it was blah, blah, blah. But just try to, when things are tough, especially around application time and you're waiting on interviews and stuff like that, just remember to like smile and enjoy the moment, because it's thrilling and exhilarating at the same time as it is, nerve wracking. So, everything's going to be all right, I think, is what I would say.
Thank you. And finally, let's go to James.
I would say if you're going into pediatrics right now, you've already made that decision. I wouldn't even think at this point of I'm going to be PEM. I'm going to be PEM. You really should give everything an option. And once you're in residency, the purpose of peds residency is to become a good pediatrician, to learn the general pediatrics really well. So I wouldn't kind of box yourself into PEM right away. You may find that you like PEM, but the other part is if you have yet to match or anything, I would try to pick a place that has more than one of any attending. Like you don't want to go to a place that if you could get into a place that has more than one GI attending, more than one peds hem-onc attending, just so that you can get a little variety. Because if you go in there and they only have one peds GI attending and that person's terrible, you're not going to want to do peds GI. Usually there's more than one PEM attending, but I would give all the specialties an option. And then just lastly, like let's say you're going to do PEM, you can do it in so many different ways. You could be a research guy that's going to do mostly research. You could be someone that's going to do a lot of advocacy. You can be someone that, hey, I just want to do shifts and that's all I'm going to do. You can really make it what you want it to be. So just because you see people at your institution doing PEM one way, there are a lot of people out there that do it a lot of different ways. So that's one of the nice things about PEM, is that you can kind of make it what you want it to be. That's all I got.
Well, thank you very much. I think I've heard the word PEM so many times now that I don't know if it's an actual word or if it's just a bunch of sounds now. But this has been absolutely wonderful. I thank the entire panel, the five of you, the Fantastic Five, for doing this and sharing your words of wisdom. I join everyone in applauding you virtually in our own respective homes. But thank you very much for being a part of this and for sharing, some steps that students can take, but as well as like, what is it even, what is PEM, and what does the job even look like? So thank you very much. We will be, this was recorded, so we'll have the recording for people to look at. We'll be sure to get everyone's contact information so various people can reach out if you have follow-up questions. But otherwise, it is 8:03, so we were so close to that 8 o'clock mark. But I thank you all. Are there any last-minute words that you want to share, Eva?
Thank you guys all again for being here. I want to say thank you to Adam. I mean, he has been one of my best friends in medical school and he's incredible. He was president at Toro. I mean, great job on moderating. And thank you to all the panelists for being here. I will definitely send everyone who registered. I'll be able to send you the recording as well as the contact info, if that's okay, for the panelists. So you guys can also follow up and ask questions to the panelists. And I really appreciate all of you guys. And especially, it's really awesome having Mark and Molly both here. They went down different routes. So thank you both again, also specifically as fellows, for being here too. All right. So have a great night, everyone.
Take care, everyone. Bye-bye.
Bye.